Thank you, Lucho, and good evening, everyone. Truly exciting to be here at this meeting after 2 years of back-to-back virtual experiences. I'll say that this particular talk, which focuses on neoadjuvant targeted therapies, has seen a resurgence in interest following the whole emergence of neoadjuvant immunotherapy as an effective intervention for early-stage non-small cell lung cancer. Clearly, the progress that has been made with targeted therapies in the advanced stage disease has not been matched when it comes to integration of these agents in the earlier stages of non-small cell lung cancer. This year, we will complete almost 20 years of targeted therapy era in non-small cell lung cancer. Some of us remember the days where gefitinib and erlotinib were still in clinical trials and phase 1 and 2 trials. And we've now seen EGFR targeted therapies move from first generation all the way to fourth generation, as you heard from the previous session. But in early stage non-small cell lung cancer, we're still grappling with what's the right approach. Is it monotherapy? Should it be combination? Is it neoadjuvant? Is it adjuvant? And these are issues that I don't think we'll have answers from this presentation, but certainly when we look at the adjuvant data with EGFR TKI that you'll hear from the next presentation, at least we can now say that we have made the first steps towards integration of targeted therapies in early stage non-small cell lung cancer. So these are my disclosures. What I'll do during this presentation is to review the existing data with targeted agents in early stage non-small cell lung cancer. Now, I know that tomorrow we're going to be talking about neoadjuvant immunotherapy, but regardless of whether you're talking about immunotherapy or targeted therapy, when it comes to early stage non-small cell lung cancer, we've all known for a long time that micrometastases happens early. Adjuvant platinum-based chemotherapy is beneficial, but the improvement in 5-year survival rate could be as low as 4% in some patients to as high as 15%. And there's always been an interest on preoperative therapy based on what we've seen in breast cancer and certain other cancers, where it is now routinely applied as part of standard of practice. In non-small cell lung cancer, clearly preoperative therapy has many advantages. You're able to give the treatment in a patient who is naive. You have the chance to treat micrometastatic disease at an earlier time point as opposed to 3 to 4 months later on. You also can get a sense for how sensitive that particular patient's tumor is to systemic therapy. And we also get to understand early on whether there is a response, clinical response in the form of tumor response, nodal downstaging, and so forth. However, so far, we've never been able to show that preoperative therapy is superior to postoperative therapy. So that's something that we need to keep in mind. Preoperative therapy can be effective. Is it going to be superior to adjuvant therapy? And that's what our surgical colleagues are going to ask us when we advocate for preoperative treatments. And the answer may be that there are some patients where preoperative therapy is advantageous and some patients where postoperative therapy is more practical. And I think that's something that we will all have to come around with developing guidelines as we see more of these data. So let me review what we know about preoperative targeted therapies. Let's start with EGFR, since that's where most of the information is. But as I show you these studies, you will see that these are smaller studies. The sample size is small. Some studies did not utilize molecular selection. And the response rate, or whatever the primary endpoint, has also varied from one study to the other. This is a study of erlotinib in the preoperative setting. This was not restricted to mutated patients. So this is one of those early studies in the pre-EGFR mutation era. Here, the response rate with preoperative erlotinib was about 35%. Favorable pathological response, which is a loose term, was about 23%. So some suggestion of activity when erlotinib is used in the preoperative setting. What about gefitinib? Once again, a very small study. This was a study in stage 2 and 3A patients. This was selected based on exon 19 or 21 mutation in the tumor. Patients got about 6 weeks of gefitinib therapy. The response rate was respectable at 55%. Major pathological response, which is defined as remnant tumor tissue of less than 10% after preoperative therapy is about 25%. Median overall survival was not reached. And they noticed that patients with a major pathological response had a much better clinical outcome compared to patients without a major pathological response. The randomized study that is available for us is the emerging study. This has been reported in multiple meetings. This was specifically for stage 3A patients. These are N2 positive patients. And this is a group of patients, I know Lorenzo and others would agree in the surgical community, these are patients who require some form of preoperative systemic therapy before they go on to the OR. Here, patients are randomized to erlotinib or cisplatin gemcitabine chemotherapy. This is, again, a small phase 2 randomized study. The primary endpoint was response rate. The secondary endpoints included pathological complete response rate. And then after surgery, patients in the erlotinib group were allowed to take erlotinib for about 12 months. In the chemotherapy group, 2 additional cycles of chemotherapy were administered. They screened about 380 patients. 72 patients were randomized, 37 to erlotinib group, 35 to the chemotherapy group. And key number, of course, is out of 37 patients are assigned to erlotinib, 31 were able to receive surgery. In the 35 patients assigned to chemo, only 24 patients underwent surgery. When you look at patient demographics, the main point I want to make here is about half the patients had single-station N2 disease in both groups, half the patients had multi-station N2 disease. There was also higher prevalence of exon 21 mutations in this study compared to contemporary stage 4 studies where 2 out of 3 patients tend to be exon 19. There was no question that the PFS was improved with erlotinib. The median was 21.5 months compared to about a year with chemotherapy. Even with extended follow-up, these results held up. So preoperative erlotinib did improve PFS. However, there was no difference in overall survival. You can see here that the 5-year survival rate numerically seemed to favor gefitinib, but overall hazard ratio was 0.83 and the p-value was not statistically significant. When we look at subgroups of patients, again, no major trends suggesting a significant difference between erlotinib and gemcitabine. Most groups seem to do better with the erlotinib arm, except a trend towards patients with single-station N2 disease doing a little more favorably with chemotherapy compared to erlotinib. Now, post-study therapy obviously is an important factor. When you look at patients in the erlotinib group, at the time of progression, nearly half of them went on to receive a TKI. And then in the control group, nearly 70% of the patients went on to receive a TKI. So the investigators hypothesized that crossover therapy negated the effects of preoperative TKI in the overall survival outcome. Now, when you look at erlotinib arm and then patients who progress and receive crossover, you have to keep in mind that some patients are potentially receiving the TKI and progressed, and some patients completed the 12 months and then had a delay before their disease progressed and were reintroduced. So those are 2 groups of patients, and mixing them could potentially give you an incomplete picture of how this works. What about best response at subsequent TKI therapy? There wasn't a significant difference in response rate whether the patients were reintroduced to a TKI in the erlotinib group versus introduction of TKI in the chemotherapy group. So overall, there was no major difference. And no surprises with adverse events. With chemotherapy, preoperatively, you see the myelosuppression-related effects, and with erlotinib, you see the skin and GI toxicities. So it's fair to say that preoperative erlotinib was tolerated well and was not a major barrier. Now let's switch gears, talk about second-generation preoperative TKI therapy. This is the ASCENT trial. The plan was here to take patients with both resectable and unresectable early-stage disease. If they were unresectable, they got 2 months of neoadjuvant afatinib and went on to receive chemo-RT. If they were resectable, they had 2 months of neoadjuvant and then they went on to receive induction chemo-RT, and then they went on to receive surgery. This study did not complete accrual. The original sample size was 30 patients. Due to slow accrual, it was completed or closed early after only 19 patients had been enrolled. You can see here that 2/3 of the patients had exon 19, and patients with 3A contributed to 2 out of 3 of the participants in the study. And about half the patients were deemed operable at the time of diagnosis, and the other half were deemed surgically unresectable. When you look at just response rate with the 2 months of neoadjuvant therapy, it was about 58%. And it shows that afatinib is active in this group of patients, no surprise. Nearly every patient had some level of tumor shrinkage. Safety data are important in this setting, since you want to be able to get the patients in a physically good condition to the operative setting or to chemoradiotherapy. It would be considered a failure if the patient had significant toxicities that stop the patient from going on to receive chemo-RT or surgery in this setting. And here, nearly half the patients required dose reduction of afatinib. 5 out of 13 patients, when they went to the adjuvant dose of afatinib, required dose reduction. The grade 3-4 toxicities were seen, and 2 patients experienced grade 2 pneumonitis. So this was not the easiest of the experiences in the preoperative setting. Perhaps not a kind of experience would be conducive to induction therapy in patients with curative surgical or chemo-RT interventions. The median PFS was respectable, about 3 years, median overall survival 69 months. So in a small group of patients, while there were some concerns, efficacy was modest. Of the recurrences, nearly 5 out of 9 patients ended up with brain tumor recurrence. So the investigators concluded that afatinib is safe, feasible. There was a high rate of CNS emergence, and they were not planning on further evaluation of this regimen in view of the ADAURA trial establishing a new adjuvant therapy paradigm with osimertinib. We do have some data with osimertinib in the preoperative setting. This is a study for patients with stage 2 and 3B non-small cell lung cancer. These patients had exon 19 or 21. 40 patients planned enrollment, 80 milligrams per day of osimertinib for 6 months, and they were scheduled to go for surgical resection. The study enrolled 34 patients. You can see here that nearly 60% of the patients had stage 3A or stage 3B disease. And when you look at the clinical responses, objective response rate was 71%. Nearly 100% of the patients had disease control rate. R0 resections were accomplished in 95% of the patients. And a very high percentage of patients had pathological downstaging, 55%. N2 disease downstaging or clearance of N2 nodes were seen in about 40% of the patients. However, pathological complete response was only seen in 5% of the patients. To me, this is somewhat disappointing, since this is probably the best surrogate we have to determine long-term outcomes. There were some important biomarker correlates in this study. When you look at the pre-treatment versus post-treatment sample, there was higher recruitment of CD8 T cells in the tumor with EGFR TKI therapy. And this tells you that when you kill tumors and there is release of neoantigens, there is recruitment of immune cells, and perhaps that mechanism may also be contributing to the observed efficacy. This is an example of a patient who had T3N2 disease. Patient received preoperative osimertinib. You can see reduction in size of the tumor, and you also see substantial increase in infiltration of immune cells in the tumor. So important proof of principle concepts here suggesting pre-op osimertinib is feasible, and this is something that is being pursued further. I'll show you the trial design of NeoADAURA in a second. The U.S. effort at this point for neoadjuvant targeted therapies revolves around the Lung Cancer Mutation Consortium 4, LCMC version 4. Here, patients with a variety of targets, EGFR, ALK, MET, many of them which we reviewed earlier in the previous session. These patients get matched targeted therapy as neoadjuvant treatment, and then they go on to surgery. Patients without an actionable target will end up with immunotherapy trials and then go on to receive treatment. So this is an ongoing effort. Overall planned sample size is 1,000 patients, and it includes an academic collaboration of institutions. Another trial with a very similar concept is ongoing. This is a Nautica study where patients are assigned targeted therapy in the preoperative setting, stage 2 and 3A and 3B, based on the specific molecular target. They get 8 weeks of neoadjuvant therapy, and then they go on to receive surgical resection. This is the NeoAdora study. This is specifically for EGFR mutations, stage 2 to 3B patients. It's a large randomized trial with 350 patients. The one group receives chemo plus placebo, the second group receives chemo plus osimertinib, and the third group receives osimertinib alone. And after surgery, all patients are offered the option of 3 years of osimertinib until disease recurrence based on the ADORA data. These are the endpoints. The primary endpoint is major pathological response, which is defined as less than 10% residual cancer cells in the tumor sample. This is a global study. It started enrolling patients about a year and a half, and the first primary MPR analysis is planned to occur in approximately 2 years from now. What about other targets with neoadjuvant data? This is ALK, small study, 11 patients. Crizotinib was given, and approximately 30 days of therapy, and very promising partial response of 10 out of 11 patients, and 2 patients had a pathological CR rate. Now, one point I would like to make here is the prevalence of these molecular aberrations in early stage disease does not necessarily mirror what we see in stage 4 disease. For instance, the ETOP effort showed that the ALK fusion abnormalities are seen in less than 2% of early stage patients compared to about 4 to 4.5% in advanced stage disease. So this also adds to complexity and a practical challenge in enrolling patients to neoadjuvant therapy trials, since the prevalence of these markers are low. One study that was undertaken by the U.S. cooperative groups, the NRG Alliance study, did not complete accrual. This was specifically for stage 3 patients with ALK and EGFR, where they got targeted therapy as induction, or they received concurrent chemoradiation upfront versus targeted therapy for 3 months followed by concurrent chemoradiation. And this trial enrolled very few patients, and after a long time of being open, it was closed because of feasibility concerns. So as I wrap up, I want to make a few points. I think it's fair to say targeted therapies have effectiveness in the preoperative setting, but we have to remember what is the overall goal of preoperative therapy. It is not meant to reduce the size of the tumor. It is perhaps not meant to achieve nodal downstaging. It's really meant to eradicate micrometastatic disease. And the question is, will a short duration, 2 months or 3 months of preoperative targeted therapy result in eradication of micrometastatic disease? And based on everything we've seen and heard in advanced stage disease, I think it's fair to say that preoperative therapy with a brief duration of targeted agents is not likely to enhance cure rates. I think we're going to have to combine preoperative therapy with some form of postoperative TKI continued after the course of surgery. And at this point, I would say that the optimal duration of preoperative therapy and even postoperative therapy remains to be clarified. And it's therefore important for us, with the momentum that has come from preoperative therapy with immune-targeted agents, that we have a resurgence of studies looking at preoperative targeted agents. Another practical issue, until now we were doing molecular testing after patients have undergone surgical resection. And I think given that EGFR targeted patients may not be optimal candidates for preoperative immunotherapy, we may have to have some sort of rapid testing for some of these targets in the preoperative setting from the diagnostic biopsy before we take these patients to neoadjuvant immunotherapy or a clinical trial with targeted therapy or directly to surgery. So with that, I'll stop, and I'll be happy to answer questions during the Q&A session. Thank you very much for your attention.
Hi, I'm Dr. Roy Herbst from Yale Cancer Center. Sorry I can't be in Italy with you right now, but I'm delighted to be talking about adjuvant targeted approaches to early stage non-small cell lung cancer. Please find my disclosures on this slide. Well, we're making great progress in lung cancer mortality. These are some data from a few years ago from the American Cancer Society. And what you can see, mortality rates have declined in both men and women. Incidence has declined too, but mortality more than incidence. I think a lot of that is the advent of targeted therapy and now immune therapy. And today I want to talk about using adjuvant therapy with targeted therapy. The idea is to move our best therapies earlier in the disease. We already know that adjuvant therapy with chemotherapy makes a difference. A number of trials, here I show the CIOT trial, the IALT trial from 2004, and there's a benefit. Chemotherapy up top versus control on the bottom, no chemotherapy in patients in the adjuvant setting, a hazard ratio of 0.86, a p-value of 0.03. The median follow-up at the time of this analysis was 56 months, which is quite good. Is this a tremendous benefit? No, but it's a little benefit, and it's become the standard of care for most patients with stage 2 and 3 disease, and some with stage 1. But how does targeted therapy fit in? Well, I'm old enough to know that targeted therapy for lung cancer began around 1996, 1997. It began with the small molecule reversible EGFR inhibitors, gefitinib and erlotinib. Of course, we all now know about the tyrosine kinase receptors, the external domain that binds ligand, epidermal growth factor, or tumor growth factor alpha, the transmembrane domain, and the internal domain, where the ATP binding pocket, of course, binds ATP and activates signal transduction when these receptors come together in dimers, 2 at a time. And then, of course, we can block this action with small molecule TKIs. And the first trials of this were done in, as I said, the late 90s. This is an example of a patient, actually the woman on the right, who had lung cancer, metastatic disease, and lived for about 10 years, not curing her cancer, but with the drug gefitinib as her standard pill every day. Of course, after 3 or 4 years, in the 2004 or so, EGFR mutations were discovered, and we know that there are specific mutations in exons 19 and 21, and a few elsewhere that portend the best response, and we use EGFR inhibitors in that setting. A bit more history, of course, the FLORA trial has brought osimertinib to the front line as the drug of choice. That's an irreversible EGFR inhibitor, a drug that actually only works in EGFR mutant cells, so less toxic, more effective. It targets T790M, the most common cause of resistance. And this trial, a large trial, looked at osimertinib versus dealer's choice gefitinib or erlotinib. 2 endpoints, first PFS, then overall survival. Here's the PFS as presented originally by Dr. Soria, New England Journal of Medicine. Hazard ratio 0.46. Just a tremendous result. Again, you see the curves are both going down. So, is it curative? Probably not, but certainly it prolongs progression. Works across all subgroups, quite superior to the standard of care at the time, erlotinib or gefitinib. And then here's the survival curve presented by Dr. Ringo Lingham. And here you can see that the hazard is 0.8. So it just makes survival, resistance a big issue. But this is the drug of choice in metastatic disease. So what about, since 1997 with EGFR inhibitors, I've told you some of the story, moving from second line to front line. What about using now osimertinib in the adjuvant setting? Well, I already told you that there's a need for this. Surgery and chemotherapy are the standards in early disease, as you're hearing about at the conference. But you can see, even in stage 1B disease, the 5-year recurrence can be as high as 45%. In stage 2 disease, the 5-year recurrence is as high as 62%. And in stage 3 disease, as high as 76%. We know that the mutations are present in equal numbers now at all stages, meaning stage 1, 2, 3, and 4, you can see in an Asian set, and a US set, and a European set, pretty much equal percentage of mutations. So you can find the mutations in early disease. Now, of course, there are many more mutations in all stages of disease in Asian patients versus US patients, and that's just a fact. Overall prevalence in Asia, EGFR mutations 30 to 40%. In Caucasian populations, 10 to 20%. So the ADAURA trial looked at osimertinib as adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive non-small cell lung cancer after complete tumor resection. I'm presenting now on behalf of our committee and authors from around the world, steering committee including Yi-Long Wu and Masahiro Tsuboi. Trial was designed, I think, as you probably know, it's been a few years now. Patients with stage 1B, 2, or 3A non-small cell lung cancer with or without adjuvant therapy. Patients had to have brain imaging performed before the study. That's important. I'll show you why. They had to have non-squamous non-small cell lung cancer, exon 19 or L858R, exon 21 EGFR mutation, complete resection with negative margins, so it had to be an R0 resection. Max interval between surgery and randomization, 10 weeks if no adjuvant therapy, or 26 weeks with adjuvant therapy. Patients were stratified by stage, 1B versus 2 versus 3A, by the type of mutation, 19 or 21, or the race, Asian versus non-Asian. About 2/3 of the patients on the trial were Asian. They received osimertinib, again, the drug that beat gefitinib erlotinib, but the drug that had very good penetration in the brain. So brain metastases are a very important thing to consider in patients with metastatic lung cancer. And then, of course, the drug has both cytostatic, but also proven cytotoxic activity, randomized against placebo because nothing at the time had been shown to be a benefit in this setting. Planned duration of treatment is 3 years, treatment continuing until disease recurrence, treatment completed, or discontinuation criteria met. You can see the follow-up was quite rigorous. We actually didn't expect to present the data till now, but it was the unblinded 2 years earlier because the results were so significant. The hazard that we shot for and built the trial for was 0.70, a 30% improvement. As you will see in a moment, it was quite more than that. The primary endpoint, DFS by investigator assessment in stage 2 and 3A. And then the secondary endpoints is the overall population adding in the ones, landmarks of 2, 3, 4, and 5 years. We're getting to the point where we'll be showing these sometime, hopefully, in the next 6 months or so. Overall survival is maturing, still cooking right now. Safety, I'll show you a little safety and quality of life today. The IDMC looked at the data 2 years ago, April, and said, hey, these data look pretty good. We have to apply in the trial. After many discussions, that happened, and it was a plenary at ASCO that year. The baseline characteristics are pretty much equal between the two groups. I just point a couple of things out to you. I told you it was about 2/3 Asian. That's stratified. It's equal in both groups. Smokers and non-smokers equal, pretty equal in sex and age. Brain imaging, everyone had to have brain imaging. You can see that a worldwide study could be an MRI or a CT. There are a few more MRIs in the osimertinib group, but not that significant. Staging about 1 to 1 to 1. Histology, almost everyone had adenocarcinoma, a few slipped in. Mutations, equal number, but a few more exon 19s. And adjuvant therapy, 60-40, and it was equal in both groups. Well, here are the data, and the data were, phenomenal. Stage 2 and 3A patients, the primary endpoint. You can see the osimertinib versus control, hazard ratio 0.17, p-value less than 0.0001. When you add the 1Bs in, a group that would be 50% cured on their own without anything, you can see that only takes it to 0.2, 80% improvement with p 0.0001. So quite profound data. We expected this trial to be positive, but by this magnitude, no, I did not. Then you can see by stage, of course, the biggest benefit is always in the stage with the most risk, stage 3A, but also stage 2 and stage 1B, blue being the osimertinib, orange yellow being the control. Actually, you see the control doesn't, the osimertinib curve doesn't change too much, but the control, of course, does. Patients do a lot worse for stage 3 disease. Forest plot, like the one I showed you in the metastatic setting, everything to the left of 1, whether it be sex, age, smoking history, race, stage, all 3 stages I just showed you. The mutation a little bit better for exon 19 as it's been seen across the board with studies with these inhibitors. And adjuvant therapy, yes and no, both positive. Here's an earlier snapshot at survival. This is only at 5% maturity. The 2 years have now passed. At some point, with a preset margin determined with the FDA and other authorities, there will be another survival analysis, and I'd be very excited to show you that when that time comes. Right now, we have a very early snapshot. Hard to say much here, but at least even at this early time, the blue curve being the osimertinib, the yellow being the control. Additional things, local versus distant recurrence, I'll show you that now. The sites of disease recurrence, we've been very focused on that. What are the subsequent therapies? The trial's been amended as soon as the results were presented 2 years ago so that everyone has access to crossover at metastatic presentation. And of course, quality of life in an adjuvant trial where the standard of care would be nothing. We worry in lung cancer about metastases to the brain, the lung, the liver, the bone. So we looked at this. The brain is a common site of recurrence. Of course, that was seen in the RADIANT study. Osimertinib, as I mentioned, is a very good exposure in the brain. It gets across the blood-brain barrier, and the brain is often the first place to see metastases. And in the advanced setting, first-line osimertinib demonstrated superior overall survival and a 52% reduction in CNS progression compared with its predecessors, alatinib, gefitinib. Well, if you look at recurrence, 11% of patients in the osimertinib arm had disease-free survival events versus 46 patients in the placebo. So here's the osimertinib arm and the placebo arm. So in the osimertinib arm, as you would expect, for those patients that did break through, 38% were distant and 62% were local, so more local than distant. However, in the 46% in the placebo arm, most of those recurrences were distant, suggesting, as we would have hypothesized, that the osimertinib prevents metastatic spread. Now, sites of recurrence, of course, the lung, he has 46 versus 11, 18 versus 6, lymph nodes 14 versus 3. But look at this, brain 10 versus 1. So, and bone 8 versus 1. But I just highlight the brain because that's a source, as I mentioned, of great worry, of great morbidity, of great pain and suffering for patients. And you can see CNS recurrence and the placebo arm at this early cut, 10% versus 1% for the osimertinib. And then if you look at disease-free survival with the brain as the first site of recurrence, the top curve is on the patients who were on the osimertinib, and the bottom curve are those who were on the placebo. The hazard ratio for brain recurrence, 0.18, p less than 0.0001, and 82% improvement. What does this mean? This means that the osimertinib keeping the brain clean. Now, what will happen as the drug stops and as we have longer follow-up, that's something that hopefully will be presented in the near future. Safety-wise, drug, again, always going to have more side effects when you use a drug versus a placebo, but you can see a couple of things. If you look at any grade 3 AE, 20% in the osimertinib versus 14 in the placebo. AE leading to death is 0 versus 1, which is important because everyone's worried about interstitial lung disease. AE leading to discontinuation, 11% versus 4%. Osimertinib more, dose reduction 7% versus 1%. Here's a tornado plot. It shows it better. The light colors are all AEs, and the dark lines are the grade 3, 4. So you can see more diarrhea, more paronychia, cough, stomatitis, pretty much everything more in the drug arm, of course, but grade 3, 4, only 2% serious diarrhea, 1% serious paronychia, 2% serious stomatitis, 1% serious aptopite, 1% upper respiratory tract infection. And grade 1, 2 interstitial lung disease was reported in 10 patients. In the osimertinib arms, only 3%, but all grade 1 and 2, no one died. And QTc prolongation was in 22 or 7% of patients in the osimertinib arm and 4% in placebo. Adjuvant chemotherapy use, as you would expect, stage 3A more than stage 2 than stage 1B, 80% of the 3A, 71% of the stage 2, and 26% of the stage 1B. You can see a little bit more with younger patients, about the same based on performance status, a little bit more in Asia, interesting. But here's DFS patients with and without adjuvant chemotherapy. So in those who got adjuvant chemotherapy, the 2-year landmark, 89 versus 49, the hazard 0.16. Without adjuvant chemotherapy, the 2-year landmark 89 versus 58. The hazard 0.23. Of course, the control group does better here. It's different populations. If they didn't get adjuvant, there were more stage 1s there. And here you can see hazards for stage 2, 3, 1B, 2, 3A, all with or without chemotherapy, all to the left of 1. What about quality of life? That was carefully looked at. Dr. Major presented this as a meeting and manuscript now published. You can see we looked at the SF-36 physical components shown here, 4 physical components, 4 mental components. It was done pre-surgery chemotherapy and all throughout the trial. Excellent compliance, well over 90%. You can see that the placebos on top in the orange, the osimertinib is in the blue, but for the most part, the curves are almost identical within the limits of error of the test. No significant decreases in quality of life. We're very pleased to see this. And you can see all the different tests, and while they all the different categories, and while the osimertinib is consistently down from the placebo, as I would expect, it's not down within the limits that would suggest that there's a problem based on the prior data with this scale. Here you can see time to deterioration of physical and mental components. You can see that the physical and the mental components are pretty much equal, so with placebo and treatment. So adjuvant osimertinib is the first targeted agent in a global trial to show statistical and significant clinical meaningful improvement in DFS in patients with stage 1B, 2, and 3A non-small cell lung cancer. 80% reduction in the risk of death recurrence with osimertinib, and at 2 years, 89 versus 52%. Adjuvant osimertinib demonstrated clinically meaningful improvement in CNS DFS compared with placebo. And the safety profile was consistent with what would have been seen with other TKIs and with osimertinib in other trials, including the metastatic setting. We saw a benefit with and without chemotherapy. Higher disease rates in the adjuvant arm with chemotherapy, of course, because of selection, and health-related quality of life was maintained, and brain metastases were prevented. So osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutant non-small cell lung cancer after complete resection. The next steps are NeoADORA, using this in the neoadjuvant setting. That's ongoing. LAURA trial, what about stage 3? We use durvalumab in most patients with stage 3, but what about those with EGFR mutation? Combination studies and other agents. Resistance is, of course, an issue. So what other agents can we combine, either with osimertinib to prevent resistance, or with or after osimertinib if resistance develops? And then, of course, there's the potential to test other drivers in this setting. And I think that's something that we'll see more of as we have so many new drivers in lung cancer. It's imperative to test for EGFR and maybe someday for other drivers at the time of surgery. So we know these data, and we can talk about this with the surgeon as medical oncologists like myself when we start adjuvant therapy. I want to thank you. I wish I was in Milan today. I really had hoped to come, but given the world situation, it's much better for me to be here at Yale, and I'm trying to limit my travel. But thank you all very much, and hope to see you next year. And I'll miss the cocktail hour. Thank you very much.